Good morning. Let's give it a couple of beats for our attendees to log on and get settled, but welcome to the Alzheimer's Disease and Related Conditions Advisory Committee meeting. Today is May 7th, and this meeting runs from 10 a.m. until 1 p.m. So we welcome you to this virtual and in-person space. My name is Carol DeAndres, and I am the MPA Master Plan for Aging, MPA Stakeholder Engagement Manager for the California Department of Aging, or CDA. Next one. There we go. As you can see, you can join the meeting by your phone, by your tablet, computer, and phone. And after we conclude this, you will be able to access meeting slides, recording agenda, etc., on the Alzheimer's Disease and Related Conditions Advisory Committee webpage, which is on the California Health and Human Services website, CalHHS. Today we have American Sign Language, ASL. Thank you, Evelyn and Bailey. And let's find, we will mute everyone, except the meeting room is not muted. We have American Sign Language, and closed captioning is available for you. You can initiate that by hitting your CC icon, which for me is at the bottom of my Zoom toolbar. And if you can't find it, check under those three dots. The more function, it might be hiding under there. Next slide. So this is for our guests that are in person at the California Department of Aging offices. In the event of an emergency, you will be asked to evacuate the building, and you are seated with our staff, CDA staff members, and they will direct you to the stairwell and to the relocation site. So thank you for paying attention and working with our CDA staff in the unlikely event of an emergency. Next slide. Virtual meeting operations. And before I get that, please, for our members and our guests that have logged on, please check your name display. It may say ADRC, AC member and guest. We would like to know your name and your organization if you'd like. So if you could please right-click on your upper right corner of your video. You have a rename function. Please rename your name display so we know who is with us today. The chat function is enabled for the committee members, California Department of Aging staff, and other state staff and our guests to share out meeting-related materials. And we invite the public to view that content in the chat. The chat is not enabled for the public to provide comments, but we do have a public comment period at 12:30. So we ask you to hold your comments until that time, and we will have public comment, and we will go over the logistics for that, but you can raise your hand and provide comments, oral comments to us at that time. Do note that we have an email box, and we can accept your comments at any time. Please email to engage, engage@aging.ca.gov. Next slide. So this is our public comment period. Just heads up for that. In-person comments, if you're in the room, you can raise your hand and Brian Carter will call on you. Verbal comments for our attendees online. You can hit the raised hand icon on your Zoom toolbar, or if you phoned in, it is *9. And of course, written comments at any time to engage, engage@aging.ca.gov. Do note that we are limiting comments to 2 minutes each so that we have time for everyone. So we appreciate you being aware of that. So, Dr. Canio, I'd like to invite our committee chair, Dr. Wynn Canio, to start us off. Thank you.
Thank you, Carol. Good morning, everyone. I'd like to officially call this meeting to order. Welcome to the Alzheimer's Disease and Related Conditions Advisory Committee meeting. Thank you for joining us today. And before we begin, I want to remind everyone that this meeting is being conducted in accordance with the Bagley-Keene Open Meeting Act, which requires that our discussion and decision-making remains transparent and open to the public. So if you are a committee member, please turn on your camera so that we have a clear visual record of attendance and participations. Go ahead and go to the next slide. This is our agenda for today. We will have opening remarks from our director, and then we have some great speakers that will talk about older adult behavioral health, and then follow with the legislative update with public comments and finalizing our recommendations to our secretary. Go ahead and go to the next slide. We will now take roll call to confirm who's present. If you could please have the names are already here on the screen. So Wayne Canio, Behavioral Health Representative. Carlos?
Here.
Senator Aragon? Do we have a representative? Okay. Sally Bergman? Claire Day?
Here.
Next slide. Dr. Farias? Tony Gonzalez, I think he's not able to make it today. Dr. Ju?
Present.
Great. Barbara?
Present.
Dr. Walter Miserly?
Here.
Go ahead, go to the next. Oh, Dr. Mobley?
Here.
Munir? Is Munir with us? Okay.
I see him, but maybe his mute is an issue.
Okay.
Lanier's here, yes.
Stephanie?
Here.
Assembly Member Pellerin?
I'm here on her behalf.
Great. Dr. Kazi?
Here.
Celine?
Celine is not here. She responded she could not be here today.
Kate?
Here.
Julie?
I'm here. Thank
And
you.
Dr. Thompson?
Yes, I'm here. I can't get on the video though. I'm in a hospital setting right now and not allowed to use the video. So I'll be on the audio only.
All right. Thank you. Do we have a quorum? Brian or Carol?
Yes, we do.
Excellent. Great. So now I'd like to welcome the new members of our committee. We have Munir and Tony. As mentioned, Tony's not able to make it today, so he'll join us at the next meeting. Munir, are you able to unmute yourself and introduce yourself and tell us what inspired you to apply to serve on this committee?
Sure. Yeah, good morning, everyone. Well, I'm honored to be part of this committee to begin with. What inspired me really was my dad's experience that I had with him. He passed away about 4 years ago with dementia, and I was lucky enough to spend some time with him. And it was a very difficult experience, obviously, to watch somebody who had been independent all his life, and all of a sudden he was totally dependent on, someone to take care of him. We didn't know who he was. Every morning he would wake up and say, "Who am I? What am I doing? Who are you?" And that was pretty tough experience to watch. And then 2 years ago, I was diagnosed with MCI, the mild cognitive impairment. And so then I started my journey on learning more about dementia and Alzheimer and the whole situation. And fortunately, I had Dr. Kazi as one of my neurologists who was helping me and guide me through the process. And so my condition is stable. But what I'm learning a lot about is really prevention is one of the key factors. As bad as dementia is, at least it gives you early warning as, early as 10 years, even 20 years, some people say. So there is time to act upon, change the lifestyle, the diet, and the whole experience to really, if not uh, make it worse, but at least you can stop it from getting worse, if not cure it at this point in time. So when this committee situation come about, and Dr. Kazi is the one who introduced me to the committee, I thought this is something where I may be able to contribute something based on my experience in the corporate world, as well as my experience with my son, who was born with cancer, with the healthcare industry, and my own condition now. That hopefully I can make some contribution to the committee. And I'll be happy to help any way I can.
Thank you so much, Manir, for sharing that and joining our committee. We will, to learn more about our members, please visit the committee member bios on the ADRCAC webpage. We also would like to share with you that Tony and his wife, Corey, as mentioned, who are not here today, but were featured in 2 compelling documentary films, Living with Love and Simply Corey. Links to both of these documentaries will be shared in the chat for those interested in viewing them. And now for our recruitment updates. So the California Health and Human Services Agency, with support with the California Department of Aging, is still seeking to fill up 2 seats on the Alzheimer's disease and related conditions advisory committee with individuals that represent first responders. That includes, but not limited to, emergency medical technicians, paramedics, law enforcement, and firefighters. So if you know anyone and interested in joining this advisory committee and offering their knowledge, expertise, and leadership, please encourage them to apply to the committee via the online application located on the ADR CAC webpage. All right, I think so next we will move on to approval of the February meeting minutes. Do I have a motion to approve the minutes as presented?
So moved.
All right.
Okay.
Do I have a second? Is that Dr. Mobley?
Yeah, second.
Great. So all those in favor, please say aye.
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 Any opposed? Any abstaining? I think we should have at least one. All right. The motion carries. The February meeting minutes are approved. All right. So I think we're moving on. Oh, did somebody say something? No. Okay. So, up next to provide our opening remarks, we will hear from California Department of Aging Director Susan DeMorris. Here you are. Thank you.
Right. Thank you, Dr. Canio. And good morning. Welcome, everyone. Thank you for providing a quorum for today's meeting, all of you who are joining. And Munir, a very special welcome to you today. Thank you for applying. We're already better for your service having you here. You make me think we're celebrating a few things in May. May is Older Americans Month, and the theme from the Federal Administration for Community Living is Champion Your Health. And that's what you're doing. That's exactly what you're doing, serving as a member of this committee, not just championing your health, but the health of others living with MCI. So thank you very much for joining us today. We're also celebrating Older Californians Month in May, and the theme for Older Californians Month is Start the Conversation. At the California Department of Aging, we want to make resources known and available to everyone in the community so that when they start the conversation about their current, future, or emergency needs, they know where to look for help and resources. So that's the campaign that we're running. This month, we anticipate a proclamation from the governor in May to commemorate Older Californians Month. It's also Mental Health Month. May is Mental Health Month. So I couldn't be more pleased with today's agenda and topics and expert speakers. So thank you, everyone, for assembling such a great and substantive and timely meeting agenda. We're very fortunate. Dr. Canio, this is her specialty. She wears many hats as a psychiatrist and a geriatrician. Is that right? Yes. So I believe you sit in the mental health seat on the advisory committee, but you bring so much more in your leadership role. I know Barbara McClendon's been working doggedly for decades on the topic of behavioral health and Alzheimer's and dementia. And we're joined by experts who will educate us. Carla, it's good to see you. And a lot's happened. And Elena, great. Great to have that to look forward today. It's also Public Service Recognition Month. And so I wanted to give a shout out to a quiet, steady Representative Julie Soulier, who's always with us, supporting this advisory committee. Julie works for the Health and Human Services Agency for Secretary Johnson. Julie, thank you for your service to this committee. And we're joined today by a new, not new to the Health and Human Services Agency, but new to the aging portfolio. Deborah Cooper, welcome to you today. And to the CDA staff. Also, public servants, thank you for everything you do year round to support this advisory committee, and especially on meeting days like today. May is also, I don't know if this is a celebration, but May is also an important month in the state budget. We ordinarily have a May budget revision. It's referred to as the May revise, and that will be coming out within a week or so. And that's when the governor and the Department of Finance adjust their projections from January based on tax filings in April. So that will be happening soon. And I can assure you, we are watching closely, working in unison with our sister departments and agencies to do everything we can to defend and protect programs that support individuals with Alzheimer's and dementia and their families. These are very difficult times with a state budget deficit and the impacts of House Resolution HR 1 at the federal level that's already having direct negative impacts in California. Also on the budget, and you'll be getting a notice when that comes out, and typically our Secretary, Kim Johnson, hosts a stakeholder call. You'll all be informed of that if you want to join and listen in when the May revise is released. During budget hearings earlier this year, Assemblymember Corey Jackson, who's from the Riverside Inland Empire area, his budget committee had asked for a special report on California's No Wrong Door system. And you'll see in your chat that we provided at the budget hearing a comprehensive report on California's No Wrong Door approach. And that's been a topic of discussion here at the advisory committee. So we wanted to be sure you all saw that. And we're really delighted that the legislature is taking an interest in that topic, and it was a wonderful exercise for the Department of Aging to lead, to really quantify all of the work and progress that's been made by the state, the federal government, and stakeholders over decades, and also coming to the conclusion that we still fall short as a state with a no wrong door and a single point of entry and streamlined, seamless access to services. And I can't think of a group that suffers more from that than people living with Alzheimer's, dementia, and their families who don't have the benefit of a no wrong door. But The conversation is alive and it's being addressed by the administration, the legislature, and stakeholders. So you'll see that report. Thank you for sharing that in the chat. And then at the federal level, there are two activities, two really positive activities. The RAISE Family Caregiver Act. This is a federal initiative that has declared that family caregiving is a top national priority. RAISE in this case stands for Recognize, Assist, Include, Support, and Engage Families in Care. A large piece of what is discussed is caregiving for people with Alzheimer's and dementia and related conditions, but though it's not exclusive to this topic. They just had a 2-day meeting in Washington, D.C. CDA, our California Department of Aging, was invited to present about our grant that we're leading that you've heard about in prior advisory committee meetings. And they renewed their commitment to family caregivers. There's actually a small by federal standards budget augmentation in the president's budget for family caregiving. And we have heard from the administration on community living that family caregiving is a top priority. There's also a challenge grant out right now, Health at Home. And this is part of the Make America Healthy Again federal agenda. But we are in conversations with lots of partners in California. California was singled out for this challenge grant as being especially ready to apply and to be competitive. So we're having conversations with our community partners, our area agencies on aging to pursue this federal funding. And what it would do in effect is look at models and pilots and evidence-based programs that help support people in their homes and encourages community living and avoids or delays long-term care placement or institutionalization. So hospital or long-term care placement. So more to come on that, but it is an exciting funding opportunity and there aren't many of those these days. So with that, I'll turn it back to Dr. Canillo, and not sure if there are any questions, but I'm here for the duration and the conversation today. Thank you all.
Thank you, Susan. All right, we're moving on to our older adult behavioral health part of this meeting. And
Yeah,
this will be,
Dr. Kenya, Faisal Kazi, may I say something quickly?
oh, go ahead.
Just a quick comment. I'm actually transitioning from this committee and from the Commission on Aging to the Osteopathic Medical Board. So this would be my last meeting, and then our commission, California Commission on Aging, will appoint another representative to be part of this committee. But I just wanted to let Susan know that I've had the privilege of really spending a lot of my time on the commission under her leadership, and the strides we've made are tremendous and are beginning to show results. So I appreciate the work of CDA, our Commission on Aging, and of course, the great partnership with the Alzheimer's Commission here. So thank you so much.
Thank you for those comments. Thank you. We'll miss you.
Yeah, we'll miss you. And thank you so much for your contribution to this committee. All right, so as a behavioral health representative for this committee, it is my pleasure to introduce our next discussion, Focus on Older Adults Behavioral Health. Our speakers today will share valuable insights, perspective, and expertise on the behavioral health needs of our older adults and the importance of addressing these challenges with compassion and collaboration. So now I'd like to introduce Dr. Carla Perisinoto, sorry if I butchered your name, from UCSF, who's going to share some of her enlightening research on the effects of isolation and loneliness on the health of older adults. Take it away. Thank you.
Great, thank you so much. I will share my screen. Give me one moment. Let's see if okay. All right. So just for a way of background, I have quite a bit of information on this slides, intended really for those people that may want to spend late night reading, learning about all this stuff, since we don't have a lot of time. So don't distress if we don't get through all of it. but this is really to give us an overview. So what we're going to talk about is really talking about some definitions of social connection and disconnection, what prevalence rates look like, how we think loneliness and isolation may affect our cognitive health. We're probably not going to get into the evidence of interventions, but maybe that'll come up in questions. But I think importantly, this all has tremendous public health implications. So I want to start with a story. This is a story of a gentleman many years ago who, at the age of 93, was actually unfortunately found frozen to death. And he was found frozen to death after he had received heat shutoff notices. Now, while this case didn't start here in California, we can see something like this happening in California, and I'm sure there are cases with increases in natural disasters, potentially not being prepared for natural disasters, and we heard a little bit about that at the beginning of this talk. But what we also learn is if we go into what was written in the papers, is his neighbor found him, he fell behind on his bills, he was a loner, he was a widower, he had no children, and family had not seen him because of a family feud. So I bring this up because there are evidence here that it's probably a good amount of loneliness and isolation that ultimately impacted his death, in addition to what were signs of some cognitive impairment. I highlight in the bottom a paper that I wrote a couple years ago looking at causes of death. And this is how it relates to public health. Because often what we see on death certificates may just be frozen to death or death from natural causes. And we're not actually talking about the death that may ensue from isolation or from cognitive impairment. I'm hoping this can help frame our discussion. So the question is for him again is, did loneliness or isolation contribute to his death? And what do we mean by these? So when we talk about definitions, I think it's important to frame some things. So this graphic really talks about some main definitions. So social connection is really the umbrella term that defines how we form relationships, and that has three parts to it. The structure of our relationship, so how many numbers of people do we have? And we have from his case that there weren't that many people around him. We have the function of relationships. What are the relationships in our lives doing for this? Did he have anyone, for example, to help him pay the bills? And then you get into the quality of relationships. We saw in there that he was a loner. He had family feuds, and so maybe there were challenges with interpersonal relationships. So when we think more broadly about people across California, it's important to think about all these three components and how they impact someone's ability to connect. Now, loneliness and isolation are the terms we use most often. So loneliness is the discrepancy, the subjective feeling of you don't have the relationships that you wish you had. So it hurts, it's uncomfortable. Social isolation is more about the quantifiable number of relationships. I mean, you may not be seeing enough people around you. This slide comes from the World Health Organization, who's also been doing work in this space. When we think about measurement, and I'm not talking about all measurement, I'm going to focus just on loneliness for the purposes of this talk. There's often something called the UCLA 3-item loneliness questionnaire, which we use, which is really asking people, do you feel left out? Do you feel isolated? Or do you lack companionship? As we move into prevalence rates of loneliness and isolation, let's talk about this because it depends on how we measure, okay? Lots of numbers here, but just as a brief thing to think about. In the work that I've done showed that 43% of people over the age of 60 experience loneliness across the country. That's about 24 million people. If you look at worldwide numbers, you get different numbers reported, but 1 in 6. And then when you look at isolation in older adults, about 1 in 4. And just to not be ageist and forget our young people, about 73% of teens and young adults are struggling with loneliness and/or isolation. And these numbers you'll see represented not just in California, but across the United States and in the world. Now, relevant to this committee, and when we talk about cognitive impairment and disorders, and these numbers change every year, but close to 7 million people living with Alzheimer's, most people over the age of 75, which is why this is relevant to the Department of Aging. We know most are women, and we know that older Black Americans and Latinos are particular risk. So how do we put this all together, these prevalence rates of dementia, specifically Alzheimer's, and loneliness and isolation? Well, let's talk about how loneliness and health interact. So how do we think about, as we age, what predicts us or what puts us at risk for being lonely? Well, we think about this in the terms of losses, the death of spouses, changes or deterioration in physical health, mobility impairments, change in living environments, visual and hearing impairments, and then reduced social activity. So it's bi-directional, right? And what we know very broadly over multiple studies is that both loneliness and isolation to different degrees affect all aspects of our health, whether it's heart disease, diabetes, poor sleep, depression, frailty and functional decline, cognitive impairment. And all of this, of course, relates to increased mortality and higher costs, actually. How does this happen specifically to dementia? Well, we believe that ultimately, fundamentally, it's that psychosocial stress, that distress of being lonely, which is actually associated with systemic inflammation and neuroinflammation, which actually accelerates specifically Alzheimer's and likely all the different subtypes. We also think that there's changes in immune responses, very much of what happens when we're isolated, and that leads to dysregulation and suppression of our immune system. Then on the social side, there's the part that if you're lonely, that may correlate with this bi-directional, and that you then disengage. You're less cognitively stimulated, you're less activated in terms of activating your cognition, and that again impacts our cognition. And these things could go both ways, right? More cognitive impairment, you're more lonely, and more loneliness, more cognitive impairment. I have a slew of research articles that I put in the slides. I do not want to go through all of them, I think, for the sake of time. But I think what's really important to see is that we're seeing more and more research papers, both looking at the biological basis for these changes. So fascinating paper from my colleague, Nancy Donovan at Harvard, who really looked at the brain images of people with Alzheimer's or with loneliness and saw that people who were lonely had higher levels of amyloid burden, amyloid being the protein that we think is depositing more in people who have Alzheimer's. Similarly, see with tau pathology, again, these cellular level changes that we're seeing in the brain that correlate this. And so as we start to see more of these biological mechanisms, we're trying to understand, is there a way to intervene sooner to really impact either the development or the progression of dementias of different subtypes? What's also important is that we start to see some of these changes even earlier in the mild cognitive impairments as well. So we're starting, this is a small study, but I think it's important to just show the development of the evidence is that there's some folks that are almost thinking about, is loneliness a neuropsychiatric symptom that is predating or that we see in earlier stages, just like in some cases we're seeing in anxiety and other mood disorders as a precursor as part of the syndrome for dementia. What's important in this study, which is a very large study in geriatric psychiatry, looking at over 8,000 people in a large representative study, is that often when we think about loneliness and dementia, we think, is this depression, right? And what is the interaction? These are very complex things, and we could probably talk about one paper for an entire hour. But again, for the importance of this conversation is that we see some of these changes, the loneliness at baseline, predicting cognitive decline, regardless of whether someone had depression. Why is this important for our work here? As we think about behavioral health services across California, how do we untangle the needs for people to address truly diagnose clinical disorders such as depression and anxiety? And how does that differ from loneliness experience? And how might we tackle that or address that at a state level? So moving on, I skipped a couple slides again, just to have them for your reference. But as a geriatrician, one of the things that I see often is people coming to me and saying, I'm on too many medications, right? This idea of polypharmacy. Well, what we know from work from one of my colleagues at UCSF, Dr. Ashwin Kotwal, is that lonely older adults experience higher rates of pain, anxiety, depression, insomnia, all these things that would fall under behavioral health. And ultimately, that results in polypharmacy. So that is a problem, both in terms of harms for older adults, costs, but also, are we trying to treat the wrong things and not recognizing what's also affecting people? As we move on, we know that unfortunately dementia can be and often is a terminal illness. And what we also see because of this is that in the last 6 months of life, what this slide shows is that we see that older adults with dementia specifically have higher rates of both loneliness and isolation at the end of life. So it's prompting us to think, for those of us that work in this field with older adults with cognitive impairment and their families, is how can we better support people in the end of life? Because of this, we also know that people who are socially isolated and have cognitive impairment use hospice less. Some people actually use emergency room less. Oftentimes, we think this is a better thing not to go to the hospital, but we also wonder, are people not seeking care out when they actually need it? When we think about those people, and actually I'm going to skip this since Elena's here, and I believe she's talking about this. Elena, Dr. Portocolone, who's an expert in talking about people who live alone, she'll talk about the experience of people living alone. But I think importantly, right, when we think about those living with dementia and their caregivers, there's some beautiful quotes we have from some qualitative work. This is from someone living with impairment who says, psychologically, it's a big downer to know that I have Alzheimer's. It's embarrassing. I think of people that have Alzheimer's and just slobbering, babbling idiots and social. Why would I want to go out and look like a slobbering, babbling idiot? This is not my words. This is someone, and this is their experience. And you can see then with this experience how someone then becomes more isolated. From a family member, my dad, when my mom was gone, was very scared and emotionally labile and easy to trigger. So friends got scared and they stopped coming. So I'm hoping by this, I've given a little bit of flavor and kind of background to how loneliness and isolation affect so many people, how it ultimately impacts our cognitive health. And ultimately, where we'll be going and having further discussions is really, how do we translate this into practice? And what is the evidence for what we can do about this? And I think that might be 2 more slides, and then I'm going to pass it along, is the questions that we have still in the research community and the health community is, how long, like, what is the time to benefit? How long do we experience loneliness before we see the negative health effects? Can we reduce the negative effects by intervening sooner? Or also, if we're already connected, how can we protect ourselves from moving forward? I want to introduce a concept perhaps some of you may or may not have heard of, is this idea of social prescribing, which we'll see more come out in the next coming years. And there's movements here in California around this, which is, how do we think about, as clinicians, as people working in public health, as people working in area agencies on aging, to really think about how do we prioritize cognitive impairment not cognitive impairment, social connection. We don't want to worsen our cognitive impairment. How do we prioritize social connection for those in our community, to talk about how this impacts our health risks? And I will stop there and pass it along to my colleagues, I believe.
Brian, I think you need to unmute the room.
How's that?
Yes, thank you.
All right.
Good
Okay.
morning.
Can you hear me now?
Yes.
All right, so I'm gonna throw this out to the committee. We want to discuss this, this presentation. Any questions or answers, or just, just general discussion, because this is, really, important to note. Anybody?
Carlos, I'm sorry, I missed what you just said.
Anybody have any discussion about the research that Carla just explained in her presentation? Any
Yeah,
questions?
I'd like to ask Carla, thanks, Carla, that's really helpful, and it's very impactful to know that there's research out there. My question is, uh, uh, what can we, what prospective studies have looked at actually trying any number of different social interventions to reduce loneliness? In other words, through reducing isolation to reduce loneliness, or other measures that people have considered. It seems to me that this is such a huge problem. There really ought to be a very specific focus on funding work that would prospectively test, what methods would be most useful in really reducing loneliness in whatever, not just the folks that are, having cognitive problems, but way before that, in just the normal elderly population.
Yeah, that's a great question. And I would say, I think there's two ways to look at this. One is it's important to think about a lifespan approach. And when we think about public health and prevention, so though I'm a geriatrician and I'm most concerned about the people and the older adults I take care of, I'm also a parent of a 5-year-old. And so I think about, how do I protect my 5-year-old now and protect her social connection so that she in later age and across her lifespan does well. So I think there's that perspective. But when we narrow in on older adults or just social connection in general, when you look at the evidence for interventions so far is pretty mixed. And that's for a couple of reasons. One, we've had some measurement issues in the field, and we actually just held a PCORI, a Patient-Centered Outcomes Research Institute meeting in Washington, D.C. last month, where we convened a group of people to say, what are we actually talking about and how do we measure this? Because as you can understand, when we're looking at interventions and outcomes, well, it depends on what the initial question was. And so that's kind of a background. But I will also add is that our UCSF team has actually done a fair amount of research on interventions, and the two that I can highlight here, which I think are also relevant to behavioral health, is the use of peers and peer programs, which have been used in behavioral health for a long time, more so in severe mental health illness and or substance abuse. But in our study, we actually looked at the use of peers specifically to address loneliness and isolation. And we did see both a reduction in loneliness and isolation and associated depression and anxiety over a 2-year period. And so that program has been, well studied. We're in the middle of a partially funded, questionable funded CDC study looking at the expansion of that program, which is like every day praying that the funding doesn't go away. And then there's also the study of a phone-based program such as the Friendship Line at the Institute on Aging, specifically for older adults. And so we do have evidence-based programs, but as we often know, sometimes even though we have evidence, the money doesn't follow, and there is more work to be done. I'll end because there's so much to say around here. The interesting question also when we think about interventions is that, how do we think about individual level interventions like peer programs versus societal and statewide approaches, right? Because there's also this part around the built environment and ageism and technology that impact how we all globally connect. And so we can't just put the onus on like me, I'm alone and I feel lonely and it's my job to fix it for myself. It's also, is my community supporting me and what is around me? So lots of stuff there, lots to talk about. In addition to what's in the chat, which is our Northern Coalition for Social Connection, together with some national partners, we are hosting a one-day social prescribing summit in May. For anyone who's interested, you can also reach out to me because, again, we're going to be talking about how do we translate some of this into practice in terms of actually providing social prescriptions and having an evidence base behind that.
I mean, I would think it sounds exactly right. It seems to me that rather than, I mean, the prescription blank that I saw sounds fine, but like how? Like, how do I make that happen? So
Yeah,
I would
we're in an
think,
implementation study on that too with a different
yeah.
project. So yes.
So Wynn and committee members, I think this is a really important topic, and that we ought to be thinking about investing in California at the very least in research on how it is that we can more carefully understand the impact, but also testing various options for engaging both sort of community-wide, but also in individual families or individual cases to really make social isolation a thing of the past for these folks. And I'm convinced that there's a way to do it. I'm convinced that the reason that the impact is quite significant. And so, you know, it's a terrible thing when you're going to be very lonely and you're old. And the case of this elderly man who just basically had no one to help him, that's just something that should never happen. So I would really say this is a really important topic that we should get behind and stay behind.
I forgot one more plug that there is a documentary coming out on PBS, I think June 1st, looking at the science of social connection. So that should be coming out, and that would be a great thing to show. There's a panel at KQAD this weekend that I'll be on also with the producer and some other folks on that. So there's work going on in this space, and more needs to be done. And I appreciate the plug for research.
Thank you. Claire, you had your hand up. Do you still have a question?
Yeah, well, I don't want to restate what Dr. Mobley just beautifully said. Really same sentiments that about getting behind it. And I think just that whole, how do we also think about bringing in intergenerational into this? And you highlighted that when you talked about community. I think that's something we should look at. You know, we work under the California Department of Aging, so we often think about older adults, and yet we have this great opportunity to think more broadly around intergenerational engagement.
And then suddenly it all goes away. Yeah.
All right. If you can hear me. Uh-oh.
I think that someone in the room has their speakers on. If you could turn that off. The meeting room should be, oh, I think it's you, Carlos. Carlos, I'm going to mute you, but you need to turn your speakers off.
Yeah, we lost
There you
audio
go.
here. We lost audio here in the room.
Oh, no.
So I threw on my headset so I could hear what we were talking about, but we went dead here for a second.
Oh, I'm sorry.
Yeah.
So we got audio back up in here, and we are good. So
Okay.
um,
Brian, just an aside, you've turned off the meeting video.
Yeah, trying to get that back on.
I'm
Okay.
trying to get that back on right now.
Okay. Perfect.
So yeah, I lost my train of thought.
I'm sorry.
It's all right. But thank you, Claire, for what you said. Although we didn't hear it, but yeah, I think we want to reiterate both you and Dr. Mobley and Carla. We appreciate this dialogue. I'm not sure if we want to move on. If anybody else had any questions or wants to discuss this further.
Yeah, let's go ahead and move on.
Yeah.
Okay, we're going to be moving on. I've been told we're moving on. So I want to thank you, Carla, and the committee members for the rich discussion. I think it's really important that we dive into this a little bit more. Now, I would like to introduce Elena Portabolon. I'm not sure if I said that right. She's a PhD, MBA, MPH, and professor at the Institute for Health and Aging at University of California, San Francisco. She's going to share with us some of her extensive research on the topic of living alone with Alzheimer's disease and dementia. Take it away, Elena.
Thank you. Thank you for having me. And
And thanks to the support of many of you in this meeting, the state of California is one of the leaders on research on living alone with cognitive impairment in the United States as well as in the world, which is wonderful. And so before next slide.
One moment, where's the mic?
It's there.
It is there,
Yeah.
okay.
Can you
Okay.
hear me?
It says it's just not, you're not too loud. Maybe-
Okay, I'm gonna talk louder. Yeah. Yes. So cognitive impairment includes mild cognitive impairment and dementia. And in terms of the next slide, and in terms of the mode of my research, I collaborate with many colleagues, including Carla, and because it's important to use different disciplines. So I need the next slide. Thank you. And this is me many years ago. And my method of expertise is qualitative research. So basically, I spend time in the homes of participants living along with cognitive impairment. And by seeing them many times, I acquire their trust. In the case of this gentleman in the Tenderloin, I saw him many times in the community room of his hotel until he finally allowed me to speak with him inside his room. And so this approach is great because it allows me and as well as researchers in my team doing this work to really go deeper and understand what are the concerns and what's really going on in the lives of study participants. Next slide. And so why living alone? Living alone is a really important trend that we need to be really in the back of our mind, because as you can see here, these are trends in United States and people of any age. And as you can see, the married couples with children, 40% of households were occupied by married couples with children in 1970. In this number, more than halved in 2022. And at the same time, people living alone almost doubled in the same time. Next slide. And this is even more common this trend is even more common in older adults, in old age. And so over half of households occupied by someone age 75 and over is occupied by someone living alone. And this percentage increases with age. So this is really, really important. So most of people in old age live alone across races and ethnicities. But policies are often framed about the old paradigm of the person with cognitive impairment living with someone, while the reality is very much different. And it's bound to stay because of important trends. Next slide. So, for example, living alone is common because of longevity. It's more common to not to have children, to not to get married. Families are fragmented. Privacy independence are important. And at the same time, also, living alone is more common in old age, as well as cognitive impairment. Next slide. And so a team of epidemiologists at UCSF found, analyzing a large national database, that 1 in 4 people with cognitive impairment live alone in the US, and this trend is very similar in California. And this population is more likely to be women, older, Black, poorer, not owning a home, be widowed, divorced, and most importantly, only 21% of this population was eligible for Medicaid. So it means that only 21% of this population is eligible for public home care aids, which is a major issue. Next slide. And living alone with cognitive impairment has risks. And just this is just a highlight. So living alone with cognitive impairment is a hallmark for inadequate support from family members. In my research, prevalently in California. In California, we interviewed over 300 times over 102 people living alone with cognitive impairment in urban, rural California over 8 years. And the dyad or the invested caregiver aligned with the person living alone with cognitive impairment was an exception. And so the living alone with cognitive impairment is often a hallmark for social isolation and inadequate support. 72% in a survey, 72% of older adults living alone with cognitive impairment reported having trouble getting any help. Then taking medication is a major issue. And our team has an article coming out in 20 days, which I will forward to each one of you about the major challenges about taking medications. And most of the participants are in California. Cognitive impairment, very likely to be undiagnosed when someone lives alone. Suicide, one of the study participants in my study died by suicide as she was in my research, and others reported suicidal ideation, and others from different races, ethnicities, urban and rural. And then, like Carla mentioned, this population is very vulnerable during natural disasters. Next slide. So I want to highlight the case of Mrs. Dolly Avenatti, who froze to death in 2 years ago, some 3 years ago, in the blizzard in the San Bernardino Mountains in April 2023. And I went there in June after 2 months, and I met with neighbors, and the only family member I had was a niece who lived in Arizona. So this woman was very gregarious. She lived nearby neighbors. Everybody knew her. She's been living there for 30 years. And despite that, there was not a mechanism to make sure that this woman, who was 93, diagnosed with dementia, living alone in the mountains, was rescued first during a natural disaster. Next slide. And here there are some quotes for participants in my research, all from California. And I just highlighted this chronic uncertainty of living alone with cognitive impairment, which is a major theme. And so, for example, the second quote was the woman who said to me, "And I'm left not knowing what to do about myself." As we were in a living room with stunning views of the San Francisco Bay, because she was very affluent, then this uncertainty is not knowing what to do applies across socioeconomic status, across races and ethnicities. And so it's really time to, now we know the problem, and it's really now time to take some actions. And a really important resource for this population are home care aides. And as I said earlier, home care aides covered by Medicaid are only available to a fraction of this population, which is concerning. And then also when the home care aid is available, as you can see in the, you don't see it in the quote. There is the home care aid, and I've got quotes that are not here. They're not really concerned about, they're not really invested in the well-being of the person. So they do their work, but they show up late, they don't cook properly. So some of them are excellent, so I don't want to generalize, but it's not, it could be better. It could be better. And also I want to point out that I'm doing research also in Sweden, in Japan, and a similar research done in Sweden. I didn't find these quotes because in Sweden, older adults living alone with cognitive impairment have home care aides, all of them. So it's automatic. So next slide. So in terms of recommendations, the policy advisory group of the Living Alone with Cognitive Impairment project propose to consider expanding the eligibility, the medical eligibility, to make sure that more people who live alone with cognitive impairment can receive home care aid and medical benefits, and also other states created a state-funded program to provide home care aids to low-income older adults living alone with cognitive impairment. And also more practically, it's really important that we find that we create protocols so that living alone is clearly marked in electronic health records, social work records, charts, so that then we can identify these persons, because living alone with cognitive impairment and other chronic conditions also being started studying living alone with cancer, it's a sign of inadequate support. So living alone, so it's really important to identify this population sooner rather than later. Next slide. And then there is a great opportunity is offered by GUIDE, this national demonstration program called Guiding an Improved Dementia Experience, that has been rolled out in the United States. And 71 organizations are here in California that are implementing this program. This program is great because it's great to support the old model of the caregiver and the diet of the caregiver and the person with dementia who live with someone. Next slide. And here you can see the services offered. But I interviewed 11 dementia experts, including here in California, and they highlighted that this program is great, but it's not designed, unfortunately, to support people living alone with cognitive impairment because of the focus on diets of caregivers and person with dementia. So I think a really great avenue. Next slide. Okay, so a really great avenue is, in terms of research, is how can we leverage GUIDE or the infrastructure of GUIDE to support people living alone with cognitive impairment, because also GUIDE has been supported by the federal government, so it's gonna stay. And then also in terms of California, I think it would be great to have a workforce focused on living alone with cognitive impairment or dementia, or living alone in general, in order to have California be at the forefront of policies and programs focused on living alone center policies and programs. And I'm very happy to serve in this workforce in any way. And then also working closely with colleagues from Japan, because of the longevity of the population, they started policies embracing the living alone of the population and the human rights of the population. And there will be an article with them that will come out in 3 months. I will share with you. But I would think it would be great to create a partnership between Japan and California in order to learn from them, and I'm sure they will be very much delighted. So this is all I wanted to share, and thank you again for your attention on older adults living alone with cognitive impairment. I'm deeply grateful.
Thank you so much, Elena, for sharing this important topic. I think now it's time for a Q&A. So committee members, do you have any questions for Elena at this time? Or comments? Doesn't have to be questions.
I just want to thank you both for your work. We've been talking about these issues for a very, very long time. And so I'm appreciative of raising awareness of these issues, and hopefully this will allow us to focus on this. This is a very tough nut to crack. So, when we look around our social services space, like we look at in-home supportive services, there's real challenges there with that program and serving people with cognitive impairment. And then we hear about budget constraints. Um, it's hard to feel very optimistic about our ability in the short term to create any kind of systemic, widespread intervention. But the stakes are so high, like even in the face of those challenges, we can't, we have to try, right? So I hope that this committee will, today won't be the only day we focus on it, that we can look for some opportunities of how can we partner with others to think creatively, to propose solutions? How can we maybe bring together other agencies within state government to think creatively about what we might do for these individuals? Because this population is only going to grow. So we talk all the time about how numbers of people living with Alzheimer's and dementia are going to increase because our population is aging and more people are living alone. And I don't personally think that we can solve this problem with some robots or some AI bots in people's lives. And I fear that that's what people are going to focus on because it seems um, less expensive and easier, and we'll just pair up older adults with some AI robots to call them once a week, and that's just going to fix everything. And it's not. So I just, thank you again.
Thanks, Barbara. Anyone else?
Yeah, I can just interject here. This is Sarah Farias. I'm the director of the California Department of Public Health funded Alzheimer's Center at UC Davis in Sacramento. And just to give a little bit of my perspective on the clinical side, I mean, unfortunately, it is not uncommon for us to see patients in clinic that are coming in for evaluation of cognitive impairment and potentially have dementia that are living alone and very isolated, don't have family, don't have friends. Sometimes they have amazing neighbors that are like serving as their family, and I'm always just amazed at when that does happen. But so many times we are left just having such a difficult time figuring out how to best support these patients that really don't have anybody. And unfortunately, we're sometimes left with adult protective services, which, is, I don't, we never really know maybe the outcome even of all of that. And it doesn't seem certainly like a sufficient solution. So thank you for all the speakers today. This is such an important topic and very hard to address on the clinical side.
So Jerry Jew here. I got a comment. NEVS runs a PACE program, and one of the thoughts that we always try to do is pair our seniors with people from high school and children volunteering. So the seniors really appreciate like piano programs and different to interact. For us, I hear it's been talked about loneliness, isolation, and its impact widely. I don't think anyone would contest that. It's really in what we do about it. So I would challenge this team, if not us, who? Things like ideas around like schools, programs like gardening or something like that. Maybe a program that we could support somehow that will interact seniors with kids. I think that's really a motto that seems to work well. Seniors enjoy seeing young people, and young people sometimes need to see and learn from and learn stories from those that have come before them. Thanks.
Thanks, Dr. Ju. I appreciate you saying that, as I think I started my journey volunteering in adult day programs and nursing homes in the Bay Area, and that's how I became a geriatrician and continuing to love what I do. And that will maybe help with the shortage of geriatrician in the country, having exposure earlier on. Stephanie, I know you had your hand raised as well.
I just wanted to thank you, Elena. One of the programs that I manage here in Stanislaus County is the MSSP program, and that's overseen by the Department of Aging. And a lot of those components you were talking about, the monthly and quarterly visits. So we have social workers and a public health nurse, actually a nurse. They provide the intensive case management. So often these staff members are the only contact that this client has. So we are seeing more cognitive decline, but MSSP has been around over 40 years in California, and we're always fighting for funding for it, but it's a wonderful model. And really to expand on that, I think would be great. It's similar to PACE, we want to keep people in their own homes with services and supports, and that's worked very well. And then we also have a friendly visitor program where peers will get trained to go out to, and they are matched up with seniors in their home and to provide that, the visits, whether it's just going to visit and play games or engage with them in some way. And that was tied to another program that just recently was cut because our behavioral services department, because changes with the law, with mental health services and funding, they're not going to be able to provide, the funding for that. So at the end of June, that component is going to be gone. And this county really, we used it quite a bit, along with, just the peer counseling, but also some behavior activation kind of program within that. So it's sad because we all know this population is continuing to grow and their needs are continuing to grow. But just to make a comment, MSSP is a wonderful model. And I think there's a lot there that could be expanded if the state can put more money behind it.
Thank you, Stephanie. Carla, and then Dr. Kazi.
Yeah, thank you. I had a commentary also about what was just presented, Stephanie. I'm a researcher, but first and foremost, I'm a clinician and seeing homebound older adults. And so had many people with MSSP, which is fantastic. What I am seeing across the state, and I'm curious what this group can do, is as there's more needs developed, the more move towards short-term case management. And it makes me really concerned about some of my, very at-risk older adults. It's not like these problems go away. And I hear the worry from some of the case managers saying, like, I'm getting pressured to close their cases. And then I have these people that are at risk and just living there. So, so two parts, like, what is the pathway for people who really need long-term case management, that it's not a one and done thing that makes it very transactional rather than relationship. And I think it's the relationship that matters, one. And then two, on the flip side, one of the things that we saw from our research with our peer program in the Tenderloin with Curry Senior Center is that many of these older adults had like 1,000 services, right? Like they had like 5,000, I mean, I'm exaggerating clearly, case managers and social workers, but they didn't have a friend, they didn't have a peer. And so, like, again, like being better to identify what is actually needed, which is to me where the social prescribing part comes, which is actually having an operationalized way to really identify what's needed. So it's not just like, here, go make a friend, because that doesn't work, but really understanding what is the deficit and better matching. So again, just a commentary on like really how messy this is and how we have the tools at our disposal. But it's probably learning how to operationalize things a little bit better.
Thank you, Carla. Dr. Kazi?
Thank you. Just as FYI, Commission on Aging has partnered with an AI or tech firm, also based in the Bay Area. It's called Eldera, and they launched a very interesting program, and we got involved into it just due to the fact that we also wanted to address the issue of loneliness. Eldera is a program that actually virtually connects 60 plus with young individuals that wish to be mentored. So that's one way to not only just leverage the expertise and lifelong lessons of our aging seniors, but also provide that space for a connection, a deeper human connection. There was a press release, and there's some contacts. I'll put them in the chat group. So I mean, we're still are discussing some concerns about, the back end security and all that. There's some, technical discussions are still continuing. But I'm going to put that information in there. Maybe have interest of researchers and others, other community groups to take a look. And then there's a contact point, a person for the Commission on Aging in the chat group as well, who you can reach out to. Thank you.
All right, thank you so much for that. Jackie?
Hi, everyone. Jackie Tompkins here at the Department of Aging, Master Plan for Aging Project Director. Really appreciate today's conversation. What I wanted to also, and I have a link ready to share with you all in the chat, is just the growing interest in also creative aging and the arts and entertainment for social connection, brain health. And so as I heard that you all were talking about different type of intergenerational activities, interventions, and programs that could be supported. I just wanted to elevate also a recent policy brief that just makes the connections to brain health as well as just that the arts and entertainment space. And I think that that is a valuable place for us to also have some dialogue about.
Thank you for sharing that as well, Jackie. All right, any other questions? Oh, Barbara?
I'm just wondering, we have a California Surgeon General, right? Don't we have that position now? And I know at the national level, I believe we have a past Surgeon General that declared loneliness a public health issue. I'm wondering if in our letter to the secretary, we could make a request that our state Surgeon General do something like that, just as a way to, again, raise public awareness of this issue and maybe marshal some state agency action.
That's a great idea. We'll definitely add that, Brian. Let's add it to the list. Thank you. All right. We can move on to the next topic. Thank you again so much, Carla and Elena, for sharing your expertise with us and the rich discussion our committee had this morning. We will now turn it to Carlos, our committee vice chair, to bring our discussion back to the effect of behavioral health on families or other caregivers for older adults. Go ahead, Carlos.
Hi, good morning and welcome. This is the only slide I have. Well, one of two. This is my dad living with Alzheimer's dementia. He's an artist. Served as a veteran on a submarine. Isolation and loneliness, I believe, impacts us as the family caregiver, as a person living with Alzheimer's. And I'm going to say the quiet part out loud. I don't think anybody's listening. I don't think anybody cares outside of this group, outside of the Department of Aging. I'm in several caregiver support groups, and there's isolation in those individuals. They need help. It's sad to see it and hear it, and I believe it's falling on deaf ears because no one's really taking the time to highlight it. We cannot underscore how much it's impacted me personally. I have a fear of missing out on just being in a room of family members at a barbecue or something, or some type of family gathering, and I'm feeling so alone because no one identifies with what I'm going through. I'm embarrassed because my dad is dropping food down his lap or meeting people on the street and talking to random strangers like he's known them for years. It's hard. It's very difficult to convey in words what I feel, and I can only assume what my dad's feeling when he's searching around the house for me or someone to help him put on his suspenders the right way after he's spaghettied himself up with them. It's extremely hard. The other day I was on social media and a advocate pretty much was advocating that caregiving needs to be a diagnosis. It needs to be its own specific diagnosis as a mental health challenge, because once we fall into this void, it's hard to get out. It's hard to get out of this low-level depression that I've been in for possibly 10 plus years of caring for my dad. It's a struggle. And then my dad mirrors that emotion that I'm feeling because I am struggling. And I don't know how he's coping with it. I know I've had to master a fake smile when I greet him, when I'm feeling down, when I'm feeling out of it, when I don't want to be in his presence. I have to fake it so he can feel comfortable. He can feel secure and safe in a familiar environment. And that matters. And how do we do that? How do I get coached? How do I get mentored to do something like that? How do all the other care partners that are out there learn how to do that? And it takes a lot of discipline, a lot of strength that I didn't think I had. It's extremely hard. There's a stigma and avoidance that I've participated in. This social prescription, I love it. I want to hear more about it. I want doctors to say, okay, we need to have you prescribed going out to the park, riding a bike. How do we get social services or, Medi-Cal to pay for maybe an adaptive bike like me and my dad have that we paid out of pocket, that can create some type of community, or just having more, elder communities out there. There was another kind of post that I saw that, there's in leadership conferences where you do this trust training and you're standing there and you close your eyes and you put your arms over your chest and you fall backwards and people catch you. That needs to happen not only to the patient, but the caregiver. These individuals, these elders that were frozen to death, who was catching them? It was a neighbor that hadn't seen them that found them. We cannot let that happen. We need to have these safety nets. Who's catching me? Who's caring for the caregiver? Who is caring for the families that are in disarray, discord in their journey, because they don't know how to do these steps. And everything they say to their loved one that's living with a mild cognitive impairment or a form of dementia is just not landing. It's not impactful. And they're not getting any lead to calm themselves, to have success in this weird, complex set of symptoms and challenges that impacts the behavioral, the spiritual, and the physical body of a human. I've been on advocacy days with several organizations, and one budget ask that stood out to me was justice and aging, healthcare for older adults, and the in-home supportive services, and that there's going to be a cut. Well, there's proposed cuts to that program, and that may leave a lot of elders out in the cold. Because maybe that supportive service individual coming to them is their only connection to the outside world. You know, as in my professional capacity as a home care aide, I've been to homes where I left very emotional. To the point where I called my boss and said, look, I can't come back. Because it was so cold and I felt alone because that person was extremely alone. You're not alone. I sketched this out. You can see it. It says, we are not alone. I wrote this in a caregiver support group because the topic in that group was isolation, loneliness. Many of us, care partners, caregivers, carers, people who don't identify as caregivers are alone. And you know, the speakers today really point out a lot of gaps and challenges that I think we face. I know the Alzheimer's Association, Alzheimer's Los Angeles, a variety of different organizations, even the doctors on this group understand that. But we need more allies. We need community members to understand that isolation is ravaging our elder communities and the people who support our loved ones. So I think that's it for me.
Thank you.
Dr. Mobley, you have a
Yeah,
question?
so Carlos, this is the voice of wisdom that we hear from you. This is the voice of the real, this is the real deal. This is the person who's really impacted. What you said is very powerful. You're living it. You're living it with some degree of depression. It's seemingly unavoidable. And I think a couple thoughts. Number one is there is enormous power in human connection. The power of people connecting with people is basically fundamental to our existence as humans. That's number one. Number two, that when you disrupt that connection, you basically tear the fabric of the human society. You basically make it impossible for people to recognize and to achieve their highest goals. Uh, Three, the changes that occur in the settings you're dealing with are not only affecting the folks that are being cared for, but they're caring for you, but you too. And I think finally, we know from the Lancet Commission that loneliness is a substantial contributor to dementia, even just on its own. So I would think Wynn and others, I think we don't need a letter to the secretary. We need a statement that says, this is an incredibly important problem. We need it. It's an urgent priority. We need a task force around stemming loneliness, finding a way that we can all live together that deals not only with the person who's affected by dementia, but the caregivers, the kind of training and fundamental research we need to really understand how to get over what is a terrible, terrible problem. And Carlos has been there for forever. It's hard to take care of people who are suffering. There's as much injury to the caregiver, to the person cared for as the caregiver. This is more than a letter to the secretary. This is a call out to a task force to study this in great detail at every level, from community to individual interactions, to training, to research, to something that really, really powerful makes a difference. And if we did it in California, we could be the poster child for the country. And Barbara, I think the Alzheimer's Association would be completely happy with this direction. You guys have been on the right side for such a long time. I know you care about this, but you can't do it alone. This is ultimately not just an organization or this committee. It's a government that's focused on reducing or abolishing loneliness.
Thank you for your words, Dr. Mobley. You mentioned something, injury. That just opened my eyes. I don't feel injured. That could be denial, and that could be also part of isolation because I don't feel that that there's something wrong with me. And that's something that my dad has said many times. No, I'm fine. There's nothing wrong with me. Even with my dad being interviewed with media or even on the documentaries we've been a part of, my dad seems like he's okay until he leaves and goes through the cycles of symptoms that are very, very prominent. Also, I want to say something about AI and technology. We are in the middle of testing a device at home, and it needs a lot more work. I mean, what happens at 3 a.m. when you have to clean up something is when that AI stuff doesn't work. You know what I mean? It's a challenge for me to kind of really say, you know what, we need technology, but we need it done right. We need more research. We need more voices of the family caregivers, and input from the professional side of caregiving to find out what's going to work, what's going to help those people that may be in the beginnings of mild cognitive impairment that just need a little support, nudging. Like, I need somebody to help me take my medication. I need somebody to make sure that I go out for a walk 3 or 4 times a day so I can keep my blood flowing, keep healthy. The human connection, engagement is the core element here of someone coming into the house and say, hey, let's go for a walk. Let's take your medication. Have you eaten today? So, how are you doing? Asking those questions, understanding who that individual is at that present moment. And that's meeting them where they're at. And I'm going to quote a dementia expert who said, dementia doesn't rob our loved one. It's our reaction that does. And as a community, as a committee, we need to start reacting and reacting in a positive way so we can validate the caregiver and validate the person living with the dementia and highlighting them and engaging with them and being more prescriptive in the social engagement. I call on Carla. You want to?
Yeah, thanks again to all these comments. And just a quick note, also just from the research perspective on tech, specifically in older adults. One of my colleagues, Louise Hockley, did a study comparing in-person, virtual, and phone, and nothing compares to in-person. And so I think it's really important we always keep that at the forefront. However, we also have to recognize that there is a part where using tech for relational purposes to help bridge and form connections is important. And so, whether this committee or the greater work that we're doing on social connection, it's really about how we're using tech and if it's a replacement. And there are some cases, for example, as we saw during the pandemic, it was probably better than nothing. There are other cases where nothing may be better because of the harms. And so teasing out those nuances will be really important across generations as much as our younger folks and our older ones. I posted in the chat this group in San Francisco. It's really a group of neighbors that are using tech as a way to form community within their neighborhood. So again, it's this idea of what's at the individual level, what's at the neighborhood level, what's at the state level, and utilizing all these resources to think about how we help connect.
Claire, you have a question or comment?
Yeah, just a comment, and thank you, Carlos, so much for your passion and comments. But when you said something, it made me think of, I think we've all been in that situation in our lives where we've lost someone, and people want to help and they don't know how, and they sort of say, well, if there's anything I can do, let me know. I think we also want to make sure that we don't create well, if there's anything you can do, we can do, let me know. With this, and make it tangible and not just something like, how are you doing versus how can I help you? How can I support you? I think it stood out when you said something that I want us to be intentional when we think about what comes next, because otherwise it will just be if there's anything I can do, let me know. Because no one does ever let you know.
That's a great point. Thank you for that. Elena.
Yeah, building on your point, Claire, it just came to mind that, for example, in Denmark, the dementia officer in the municipalities, so small areas in cities, they know who are the older adults who are living alone / isolated, and their responsibility is to check in with them and push them help. And Danish are very independent, but the officer and her quote is, "It's my responsibility to keep on asking them if I can offer them services." And in Denmark, rates are public. So that builds on what you said, in the sense that the state, the government, is responsible and proactively responsible and keeps on pushing the service, knows who are the persons who are isolated, who need help. In Denmark, if you lose a spouse, then someone comes to visit you in your home and check whether you need services. And after you become 75, every year you get checked whether you need services. You get a very thorough assessment. And so the responsibility. So I think it's not how can I do. It's I know what I can do, and I'm gonna keep on checking on you because I'm here. So it's a change of perspective.
Hi, sorry, I don't have a camera or laptop. I'm Janine Misterly. My dad passed away from dementia 19 years ago, so I'm well on the other side of that caregiver. And I guess all I can think about, part of that isolation I heard you talking about, is there's a lot of uncomfortableness for everybody else around the behaviors. And I think kind of normalizing it, Alzheimer's isn't the slobbering, goobering person, right? And showing people that MCI, dementias of all different types have different faces. And if they're more comfortable with it, I think it's easier for them to be around. We were very socially connected, but when my dad was diagnosed, as he physically declined, mentally declined, people didn't know what to do. They were uncomfortable. Mm-hmm. And he did have a good family friend who every night came over and helped them put my dad into bed because he also had ALS. And that was huge, right? But that was a very tangible thing. But yet these people who came over every night, we never saw them any other times. And so I still think it just comes back to that basic education, normalizing it. What does this look like? I think that can help us be less isolated.
Yeah, thank you for that. You're right. We need to normalize getting old.
Right.
We need to normalize dementia, all forms of dementia. And we need to normalize caregiving and the strife that caregivers feel.
I think that needs to be part of visits. I know I try very actively, in my memory care, to ask the caregivers, how are you doing? And you almost have to wonder, does that need to be part of that visit?
Absolutely. Thank you. Anybody else?
I think in the interest of time, we'll have to move on, right, Brian?
That's correct. Thank you, Dr.
Okay, just looking at time. Thank you guys so much for such a rich discussion for this important topic. I think we could have a whole day discussing this, and I really like the idea of really elevating this and having California be the model for this, hopefully with the power and the skills of our group here, we can move that forward with the help of our Health and Human Services and CDA. So now I think we're going to have, we're going to hear what is California actually doing now to address this, right? So we have Anna Acton, our Assistant Deputy Director from CDA Division of Policy Research and Engagement, to provide an overview of the Behavioral Health Services Act. And then after Anna, our committee member Barbara McClendon, Public Policy Director of Alzheimer's LA, will give us perspective on a BHSA implementation. So go ahead, Anna. Thank you.
Thank you so much. Can you guys hear me okay online?
Yes.
Yes, you sound good.
Great. It's awkward now to transition to talk a little bit about, some Behavioral Health Services Act, which is really an important topic, but I just thank you so much for the conversation. It resonated a lot with me, both on a personal and professional level. And on my way down here to this meeting, I was talking to my neighbor and friend who's caregiving for her father, who's in his 90s with dementia and going into hospice. So thank you. And just thank you so much for your attention to this. And it touches so many of us, right, in so many different ways. So I'm going to transition us off of, I think, what was a really great conversation to the Behavioral Health Services Act. And we'll go forward. Thank you. I'm going to do a quick overview. I might skip through it a little bit just because of time. I do want to hear from Barbara after about what this looks like at the local level, but want to just talk a little bit. We've talked about it before with this committee, but we have so many new committee members. We thought it'd be good to just do an overview of behavioral health transformation, which was really a ballot initiative known as Proposition 1. You may remember that from a few years back, which really aimed to modernize behavioral health services delivery. And there were really two legislative bills that were created in Prop 1. One was the Behavioral Health Infrastructure Bond Act, which allocated almost $6.4 billion to construct, acquire, and rehabilitate behavioral health treatment, beds, supported housing units, and community sites. And then the other piece is the Behavioral Health Services Act, which really looked to reform the Mental Health Services Act, or MHSA as we referred to it, which was originally passed in 2004. It was the tax on millionaires. By expanding services to include treatment for substance use disorder, modernizing county funding allocations, and updating reporting requirements to focus on outcomes, accountability, and equity. With updating the funding allocations under the Behavioral Health Services Act, this really means that many of the counties may face difficult decisions around where to invest their dollars, reinforcing the importance of older adult stakeholder participation in planning processes, and advocating for older adult behavioral health really is going to be an important piece through the implementation of BHSA, or Behavioral Health Services Act. And we can skip forward 2 slides. So just as an overview, there are really, I wanted to go over the state level investments and initiatives. So the lead oversight and implementation department is the Department of Healthcare Services, or DHSA. There is a state-led workforce initiative through the Behavioral Health Services Act, which provides new state-level funding to implement a behavioral health workforce initiative that's led by the Department of Healthcare Access and Information, or HCI. We also have a state-led population-based prevention strategy that's housed within the California Department of Public Health, which through the Behavioral Health Services Act provides new state-level funding to advance statewide population-based health initiatives. So that's under the Public Health Department. And then the development of outcome measures for the Behavioral Health Services Act really lies within the Department of Healthcare Services, which will develop statewide behavioral health goals and outcome measures, which counties will be required to factor into their local planning and reporting processes. And we'll skip 2 slides forward. So a little bit on the county's funding. So 90% of the Behavioral Health Service Act funding is going to local counties. Those local counties are required to use 30% of those funds that are distributed from the state controller's office into their behavioral health services fund. They have to be used, 30% have to be used for housing interventions specifically. Of the funding distributed to counties for housing interventions, 50% must be used to support the housing needs of individuals who are chronically homeless, with a focus on those in encampments. And then up to 25% must be used, used for capital development projects, building housing and housing supports. So there's also the full services partnership piece of the funding. It provides individualized team-based care to individuals living with significant behavioral health needs through a kind of a whatever it takes type of approach. Participants benefit from a community-based whole person approach that is trauma-informed, recovery-focused, age-appropriate, and delivered in partnership with both families and the individuals. The other piece to the funding is the behavioral health services and supports, which 35% of the funding must go to that. And we'll go to the next slide. The 35% for the behavioral health services and supports funding. And I know this is really getting into the weeds, but I'm just trying to give you kind of a sense of how the funding is going, majority of it to the counties, and how they have certain percentages of how much of the funding they have to use on these various different buckets of services and interventions. So the behavioral health services and supports funding, at least 51% shall be used for early intervention programs and services, and at least 51% of funding allocated for early intervention programs and services must be used to serve individuals under the age of 25. Okay, so you can see when it comes to early intervention with a lot of what we're talking about, you know, prevention, isolation and loneliness pieces, really, you know, this money is being broken up and there's a good chunk of the early intervention pieces that go to younger adults. So we'll go to the next slide. So a little bit on early intervention programs. These are really programs that are designed to prevent mental illness and substance use disorder from becoming more severe and to reduce disparities in behavioral health. And examples that some of you may be familiar with early intervention programs may be like the PEARLS program or AgeWise. I know Stephanie, for example, who's on the committee, is very familiar with some of these programs, but PEARLS as an example is an evidence-based program utilizing trained coaches, counselors to educate and support older adults to reduce symptoms of depression, improve health-related quality of life, reduce isolation and loneliness, and to lower inpatient hospitalization and nursing home stays. And AgeWise is another really great program, non-traditional mental health program for high risk and underserved older adult populations. So we'll go to the next piece. So the Behavioral Health Services Act mandates that counties conduct ongoing community engagement across all stages of development of their integrated plans. Stakeholder engagement requirements for the county integrated plans became effective January 1st of 2025. And it's really important that, you know, local stakeholders and those in the aging community are aware of what's happening at the local level and involved. So as part of the required engagement at the local level with stakeholders, those groups include engaging with those with lived experience, area agencies on aging, independent living centers, other community-based organizations, and behavioral health providers and peers. We'll go to the next slide. So really this provides an opportunity for stakeholders to engage at the local level and to influence the process. I'm actually going to go to the next slide real quick. So these local county plans are being developed right now and have already been submitted to the Department of Healthcare Services. But the good news is that this is ongoing engagement, and they need to renew their plans every 3 years. So if you haven't been involved and there hasn't been a lot of involvement at the local level, there will be ongoing opportunities for that. And I would say really a need. We developed a local toolkit at the Department of Aging to support local advocates, partners, and advocating for older adult behavioral health investment at the county level. And those opportunities really come through the county integrated planning process and the County Behavioral Health Services Act stakeholder engagement. And we'll have a link to them. We have a toolkit for every county that really talks about where the local engagement opportunities can occur and to help get local stakeholders connected. So with that, that gives you a little bit of an overview of what's been happening. We're in the midst of it. Those county plans have been submitted. Some of them have been finalized. Others of them have not. But I'd like to bring in Barbara, who has a local perspective, I would say, on what this really looks like at the local level.
Thank you. Thank you, Anna. So it's definitely the case that every county, is embarking on this. And so I really am just speaking from what I've seen here in Los Angeles County from conversations with providers in our community. So Los Angeles County's plan has been submitted and approved by the state. And I know one comment I can make with total certainty is that there is incredibly high anxiety across service providers who are working with older adults. Almost every one of them is facing having to reorganize how they deliver services, what they're going to be able to continue to deliver going forward. I think Stephanie made a comment earlier in our conversation about social isolation, about a program that her own organization is no longer going to be able to provide as of June. I think that's happening across the entire state, and it's really concerning. So again, community-based organizations in Los Angeles County used to be able to use MHSA funding to provide a range of early intervention services. And if you look at LA County's plan, it's just there's such a clear focus on, and we certainly don't begrudge that we see the need for that focus on children and transition age youth, but there is real concern that there isn't balance and there isn't that similar kind of focus and attention and depth of service delivery for older adults. This may be a particularly acute concern in some of our diverse racial and ethnic communities. So one thing that can happen in some communities is an underreporting of mental health needs. So it may look like this is an individual who there isn't a serious mental illness at play because of the way they're reporting what they're experiencing or what they're asking for. And those early intervention programs that these organizations used to get the funding to provide gave them a gateway for these individuals to come through. So once you're interacting with an individual, you may have thought that an early intervention program was going to be an appropriate way to meet their needs. And then through the relationship that you're developing, you realize, oh no, there's way more going on here. And maybe we need to be bringing in some of these other higher level, more comprehensive services. So if that doorway closes to providing early intervention to that individual, then, you know, we may be missing even more people from these services. When it comes to prevention dollars, take the anxiety dial and dial it up further because those are really being shifted in the way that they have been provided. And so, and again, if my understanding, so if I'm wrong, hopefully someone here will correct me, is that it is now our state's Department of Public Health that is going to be managing those prevention dollars. So the anxiety that we have here in Los Angeles County is over what that's going to look like. There's real lack of clarity on how those prevention dollars are going to be used. And again, how those have been used in the past here in Los Angeles County has been a real high touch kinds of programs. So I'll use an example from our AAPI community. So some of you may recall that there was a shooting incident in Monterey Park. And then there was actually in fairly short amount of time around that, there was another shooting in, I think it was Half Moon Bay. And both of those happened within the AAPI community. So a provider here in Los Angeles was able to use prevention dollars to create an AAPI community empowerment project. And so what they did with that was a series of workshops for the AAPI community. Again, these are prevention dollars that are being used to fund this workshop. And then what that ended up creating was an opportunity for people to come together in person in the community and talk about some of these issues related to mental health and what the symptoms are and what the resources are for people who are experiencing mental health issues. What they saw coming out of that workshop were people who said, oh, you know, I have the words now to talk about what I may be seeing in myself or in my family, and you know, reducing stigma around talking about mental health and increasing an understanding of what the resources are, and so increasing the likelihood that they were going to reach out for services. So the concern is that those prevention dollars, if instead of funding something like workshops in the community, in language, culturally, linguistically appropriate, if what we get instead is like a public awareness campaign that is very broad, and you might say, oh, I'm reaching the whole state with our public awareness campaign, but the touch is so light. And again, may not be able to be specific to different communities. And so there's concern about what's the impact going to be from something like that as compared to what those funds used to be used for. So, another just final concern that I'd like to highlight is there seems to be an expectation that some of the services that individuals may have been receiving through the MHSA program, either through prevention dollars or early intervention dollars, that these individuals are going to be able to get their needs met through the managed care plans through which they are receiving their healthcare services. And I just think we need to be very honest with ourselves about the limitations of the managed care system to really fully meet behavioral health needs. What we hear over and over again is how incredibly difficult it is to even figure out how to access those mental health services under your managed care plan. It's very hard to find providers. It's even harder to find providers who might be in language, again, culturally and linguistically appropriate. So our fear here in Los Angeles is that BHSA is being built on an expectation that the mental health services that our managed care system is able to provide is more robust than it actually is. And so once again, we are setting people up to fall through the cracks. And we are removing from our community-based organizations the funding services for the funding for the programs that used to maybe catch those people as they were falling through those cracks. And I'll end there.
Thank you, Anna and Barbara. And I'd like to open it up for to the committee for questions, answers, or discussions.
question. I know in Lathrop, I believe they're building a behavior care. Is that something that you know about? I guess is that part of this funding? There's a facility that they're building in Lathrop that is supposed to be for behavioral health services. And what I'm wondering also too is the connection between where I know that this is, I believe it's predominantly for adult ages or younger, as you said, with the younger on part of it. What is the connection with, if any, with the senior population regarding that funding? And
yeah, so some of the funding has gone out. When we take a break, I'll find the link where you can find local funded projects through the bond to do some of that infrastructure improvements. I'm seeing it around the communities throughout California where those funds are translating to building housing and treatment type of facilities. So maybe we can look and you can see for your local community. Yeah.
Thanks, Kate. Anybody else have any questions or comment? Once, twice. All right. Well, I just want to say thank you again to Barbara and Anna and the committee. I want to introduce Carol to take us to break.
Thank you very much. We do. So welcome back. If we can have our committee members turn on their cameras just to know you're back with us. And I believe we can go ahead. When I'll spotlight you as well.
Great, thank you, Carol. So next on our agenda, we'll hear the departmental updates from Tina Fung, Chief of Alzheimer's Disease Section of California Department of Public Health. And that would be followed by a legislative update from committee members Barbara McClendon from Alzheimer's LA, and then Andrew Mendoza from the Alzheimer's Association. Go ahead. I think Tina just has some verbal report. Or
Hi, everyone. Good afternoon. I'm Tina Fung from California Department of Public Health. I just have a few updates on our resources. I don't have slides for today. So the first update is we had funded several local health jurisdictions as part of our California Healthy Brain Initiative. And now the funding is over, but we have an evaluation report that has been released. So the report that evaluated our 2020 to 2022 cohort is now available online on our CDPH webpage. And I believe we'll have the link available in the chat box. We also fund 10 networks, the California Alzheimer's Disease Centers. They released an assessment of cognitive complaints toolkit in 2018, so they have updated that. Right now, they have the toolkit available online in their UCSF link. And then our last update is the facts and figures for the state of California. If you were here in the last meeting, Dr. Jarman Ye had presented on her facts and figures statistics and a lot of projections of prevalence rate for these next several years until 2050. And we are anticipating the publication of facts and figures by early fall. So the last report was published in 2021, so we're really excited to have new numbers available, and we'll share it out. Hopefully it'll be published in time for our next meeting with the advisory committee.
All right, I think it's me. Andrew and I divided and conquered here. So I'll get us started and then Andrew will finish with bills that have relevance for the families that we serve. I mentioned this one when we met back in February, I think that was. This was one of the few pieces of legislation that had already been filed. So I'm really just providing you with an update here. And I'm going to be saying the same thing over and over again here, which is that many of these bills have landed themselves in either Senate appropriations or Assembly appropriations suspense file. So what is the suspense file? It's basically like a big holding pen for legislation that either clearly has a cost or maybe has a cost. And as Director DeMora said at the beginning of our meeting today, the next week, probably maybe around Thursday, the governor will be releasing his May revised budget. At that point, everybody will be working with more solid numbers about how much revenue does the state have, what has to go to various constitutionally required directions, what's available for other initiatives. And so until we get to that point, I think just as to be conservative, safe, the Senate and Assembly committees that are tasked with figuring out where we're spending money just tend to hold a lot of these pieces of legislation until there's a clearer picture about what money is going to be available. So this piece of legislation that would establish this, if it were to pass, this is what you would see on the November ballot, something that we would all have an opportunity to vote on. Again, an effort to try to fill holes that the federal government has created with funding cuts at National Institutes of Health. And so it is sitting in Senate appropriations suspense file. So it is our hope that we'll see it come out of that file. And then, of course, it would have to pass the Senate and go over to the Assembly. But it is still alive. And so hopefully we will see it move. Next slide. Another piece of legislation, AB 1798, that's focused on trying to ensure that any genetic testing information is not used to prohibit people from being able to access life or disability insurance. So this one has passed its policy committee and has been referred to appropriations. I don't believe it's actually sitting in the suspense file. This might be the only one that I'm talking about today that's not there. There were some amendments taken in committee, but I do think that for our families, especially people who may have parent or grandparent and be seeking genetic information to make decisions about what their risks may be, we would not want people to be penalized in any way for having that information. Next slide. Oh, so it was referred to the suspense file. Thank you. I'm glad we have some legislative staff. I was hopeful there for a moment, but no. Okay, SB 1088. So this is related to basically making post forms work a little bit better, make them easier to use. So it expands who can sign these post forms. Um, so this is providing guidance for physicians on what people's wishes are. And it also would allow, so let's say if you have a mom who's been living in the state of Virginia and has this kind of information, allows smoother transfer of that information into California, so you wouldn't have to start all over again with creating a new post form for them. And this one has actually passed its policy committee, and I believe it is awaiting a final vote on the Senate floor. So I do think that this is something that would be very helpful for caregivers. So we certainly hope that, and we anticipate passage off of the Senate floor and over then, so we can start its journey through the Assembly. Next slide. SB 1149, you might recall last year there was a piece of legislation that expanded access to paid family leave to designated caregivers. So not limiting paid family leave to just the specific familial relationships that had originally been in the law. This bill sort of closes the loop because the last place where someone who may not have a particular familial relationship to an individual, but could be their primary caregiver. This would ensure that those individuals have access to up to 5 days of job protected. So this is not paid leave, but job protected bereavement leave. And this bill is in the Senate appropriations suspense file, but we are pushing really hard for this bill to move because, as we all know, if you are a primary caregiver for someone and they pass, and then you are not able to take time off from your job for those days afterward, I mean that's devastating and just unacceptable. And so this bill, if it were to pass, would at least partially protect or address the issue through that job protected leave. Next slide. We have talked about disaster and emergency preparedness a number of times in this committee, and actually we talked about it again here too today when we were talking about people who live alone and how do we make sure we keep them safe. So this piece of legislation requiring the Aging and Disability Resource Connection programs to provide this kind of training. They don't need to create it. They don't need to reinvent wheels. This training does exist. The Department of Aging has done some excellent work and guidance in this area. And so this bill has just recently, so it's out of the Senate, it's over in the Assembly, and it was just recently referred to both aging and long-term care and emergency management. So we certainly hope it continues its journey. All bills need to pass by the end of this legislative session, or they have to start all over again when the next 2-year cycle begins. So it's important that this one passes during this session. Next slide. Okay, all 4 of these are in their various houses, appropriation suspense files, but all of these are efforts by the state of California to try to protect our families from some of the damage from the federal congressional bill HR 1. So they are around trying to streamline the reevaluation process that has to happen every 6 months now, all the administrative hurdles that the federal government is putting in place, many of them effective in 2027. These are efforts by the state to try to help individuals navigate their way over and around those hurdles as effectively as they can without losing their access to Medi-Cal. So all really important. We certainly hope in the end that they will be released from the suspense file and passed. Next slide. Oh, that's it. I'm handing it over to Andrew.
Thank you so much, Barbara. You can move to the next slide for me. So this is our sponsor bill, SB 950, with Senator Weber Pearson. It is requiring for state-regulated health insurance plans to cover FDA-approved treatments for Alzheimer's disease. It bans step therapy for the anti-amyloid therapies, and then it provides non-restrictive coverage criteria and makes denial appeals exigent circumstance. This bill did receive a 9-0 vote to move out of the Senate Health Committee, and then the fiscal assessment from DMHC was that it would have absorbable costs. And then the California Department of Insurance provided 2 different estimates that equaled around $33,000 for state costs. So we were able to avoid the suspense file on this one. We got a 7-0 vote to move it out. It is currently on the Senate floor, where it's expected to be taken up for a vote in the near future. I do believe they're planning to do it next week. It will then move to the assembly and replicate that process. We can move to the next slide. I did want to share with you that the Senate Health Committee requested a report from the California Health Benefits Review Panel, or CHBRP, on SB 950's impact on premiums. The total cost to bring coverage for disease-modifying and symptomatic treatments up to 100% for all treatments would be $660,000 for the marketplace. Because there were only 23 people identified to be receiving the disease modifying treatments, there are a relatively low cost estimate that was provided for the marketplace. So essentially, Chaburp said that anything below $2 million as an estimate is a low estimate. So this is a very low estimate for a bill that they analyzed. Essentially, one of the reasons that the committee requested the analyses was because there were so many there was a lack of specificity in existing law regarding these treatments, and our experience as a direct service provider indicated that existing law wasn't being followed. So essentially, oh, if you can move to the next slide. So what the report found in terms of coverage is that for the two disease modifying treatments, they were covered at 88% for the plans that were analyzed. And then the disease or the symptomatic treatments had a very significant range. There were some that were covered as low, or there's one that was covered as low as 7%, and then one that was covered as high as 93%. So essentially, what the plans, I believe, are doing are covering one therapeutic equivalent within a subset for the symptomatic, and then the two disease modifying treatments are not therapeutic equivalent. So the plans that are covering them are covering both. And then there's one plan that was identified as covering neither of them. And that is because they have issued a national coverage decision that deems these treatments to be experimental. I believe everyone here knows that they are, of course, FDA approved, but then they're covered through Medicare and Medicaid, and then they are covered through the CalPERS provided plans. And then we are targeting specifically the state regulated plans through CDI and DMHC, which would still leave a small hole associated with ERISA plans, which are regulated through the federal government. So not to say that this is going to cover everyone that isn't already covered, but it does begin to address the coverage gap that we believed we were seeing in the population trying to access anti-amyloid therapies. So if we could go to the next slide, I can move on to our budget request. This is our sponsored request for Dementia Care Aware. I mentioned it last time we all met. Not much has changed. It is submitted in both the Assembly and the Senate under review by the relevant subcommittees on both sides. We were able to provide some supportive commentary and a coalition letter to the Senate subcommittee when they listed it on their agenda. We were very happy to have the support of Alzheimer's Los Angeles as well at that hearing. And then, as Barbara mentioned, the May revision is expected to be released next week. So the legislature will then hear a series of different proposals included in there and begin to draft their version of the budget, which will include legislative priorities. So we will know once it's published whether or not we are going to be able to continue on with Dementia Care Aware for about 3 years or so. Right now, they are out of state funding. They've been out of state funding since September. They have received a private September of 2024, excuse me, and they received a private grant that will carry them through till the end of this fiscal year. So if they don't receive state funding, they will likely cease operations. And as we discussed last time, it's really important that they continue on. They've now trained 7,450. My number is a little bit outdated now. And they say that there are tens of thousands of more providers to train so that everyone is dementia capable and can be able to perform cognitive health assessments to then be able to detect dementia early and diagnose it early as well for early intervention strategies. We can move to the next slide. So this is our other sponsored bill by Assemblymember Stephanie. So this is providing good cause to a prosecuting attorney with a Penal Code 368 case where the victim of the alleged offense is a dependent or older adult to receive a continuance for their other obligations. This enables them to carry out a vertical prosecution where one attorney handles each stage of the case from beginning to end, and this avoids handing off to inexperienced prosecutors or someone that's not as familiar with the victim or their circumstance. And this provides that a responsible attorney will hold the case knowledge, relieving the victim of having to repeat their story to multiple people. And it also provides a dedicated resource for the necessary follow-up for any caregivers that are assisting someone that's living with dementia to navigate this process. And it builds upon the experience of working with older adults and requesting the necessary accommodations that are needed in these cases, whether it's interviewing someone in a long-term care facility or a hospital room. Unfortunately, it has been observed by a few different experienced professionals that inexperienced prosecutors sometimes will determine that a witness is unreliable because they have dementia or other cognitive impairment, and they will bring lesser charges against the person that perpetrated the crime, or they will bring no charges at all. When they should aim instead to build a case that isn't solely relying on witness testimony. But unfortunately, the implicit bias within our society can sometimes result in unequitable access to justice, especially as most counties do not have a standard operating procedure for these kinds of cases. We did receive a 9-0 vote in the Assembly Public Safety Committee and a 70-0 vote on the Assembly floor, and it was just referred to the Senate Public Safety Committee yesterday. So we should be expecting to be heard after hearings resume in June post House of Origin deadline. We can move to the next slide, and then I will get through these last 3 slides. So I wanted to share this bill with you. It's SB 971 from Senator Choi that promotes healthy aging. It provides that these local entities can establish community-based programs for the education of older adults, and we are supporting this bill. It is currently on the Senate floor and is expected to move to the Assembly soon. It should provide a good resource for folks that are interested in developing programs related to brain health and lifestyle interventions, and then likewise with social engagement and independent living. So we can move to the next slide on this one. So then I have 2 bills here that are being co-sponsored by our friends at the California Association of Long-Term Care Ombudsmen, and then the California Advocates for Nursing Home Reform. So SB 991 requires the Department of Social Services to report the specific types of abuse substantiated as violations at residential care facilities for the elderly. This bill is currently in the Senate Appropriations Committee. I do believe it has been referred to the suspense file. The advocates at the bill hearing provided that right now the data that's provided about the violations are so generalized that there's not a lot that advocates can currently do to change circumstances for individuals when analyzing what kinds of abuse are happening. They were saying that essentially that someone that's wearing a mask or refuses to wear a mask in the presence of a resident and someone that had been sexually assaulted were categorized in the same category of abuse. So essentially now we would have, or under this bill, we would have a lot clearer data. And then AB 2135 by Assemblymember Colra does require long-term care facilities to provide residents with a notice of transfer or discharge at least 30 days before, and for the notice to be translated and signed by the individual and or their representative. This really just clarifies the circumstance to avoid hospital dumping and other unfair circumstances around evictions. Some of the advocates mentioned that with the relaxed rules that some residents had been evicted with as little notice as a post-it note, which is really unfortunate to hear. So we can move to the next slide, and then I'm almost done. So this is a bill that we are just watching. SB 1047 by Senator Nilo expands the data collection and reporting requirement for the California Neurodegenerative Disease Registry Program to include frontotemporal degeneration, and it extends that program until 2030. So this historically has collected data on people that have Alzheimer's disease, but now it will collect additional data for another form of dementia. So it should be something that ideally results in improved awareness and research opportunities as well. So that is the end of my presentation.
Thank you, Tina, Barbara, and Andrew for your presentation. Appreciate that. I want to open up to the committee for questions and answers.
The transition of public comment.
Oh, yeah, we're transitioning to public comment. Yeah, so I think we're moving on to Carol to open up for public comment. Carol, take it away.
Thank you, Carlos. Hello, this is our public comment period. If you have a comment and you're in the room, you can raise your hand and Brian will call on you. For those of our attendees online through the Zoom platform, you have a raised hand icon that you can engage, and we will go ahead and unmute your line. Do note that we have 2 minutes for each comment. Know that should you have comments after this meeting, please feel free to send them via email to our Engage email box. Engage, ENGAGE, at aging.ca.gov. And we monitor that, and we are happy to forward those comments to the committee. Okay, Dr. Farias, how about we give a few more beats to our attendees online, and then we will move it over to our committee side, if that's okay. If you can hold your thought for just a moment. Again, at any time, you can send your written comments to us at Engage, ENGAGE, at aging.ca.gov. And Carlos, I don't see anyone raising their hand on the attendee side. So happy to move this over to the committee for discussion, and we can bring down the slide and go to gallery. Thank you, Dr. Farias.
Yes, thank you. And thank you again to all of our presenters today. So I just wanted to let the committee here know. So again, I'm the representative on this committee for our California funded Alzheimer's disease centers. And as most of you on this call probably know, that there are 10 centers across California that are funded by the Department of Public Health. They're all at academic medical centers. We have not had an increase in the funding of these centers in over a decade, well over a decade. And so not only, does that really translate to static funding, but really a decrease in funding with the increased costs. And so I did want to let this committee know that there are two particular centers that for which the funding really is not going to be sufficient to keep those centers open. And so I just wanted to again let people know, and if there's any anything this committee can do to help with that funding and increase the amount of funding. These centers are clinical centers primarily, so we see patients, we deliver care, we diagnose, we provide ancillary services like social work and brain health classes. We do a lot of training with primary care and other caregivers, both paid and unpaid, and professional and family caregivers. And so, this is just a really important program as part of the state public health. So, yeah, I'm open for any questions if people have them. But thank you.
You talking, Lynn? You're muted.
I was. Yeah, so I think it's time to finalize our recommendations for our secretary, since it seems like there are no questions. Anything we'd like to elevate or prioritize? I know Dr. Mobley raised a few earlier, and Brian had documented them accordingly. Anything from others? Barbara.
I wonder if we could include something that would be a guidance or request of the Department of Healthcare Services as they're developing outcome measures for BHSA, that we really want to see robust outcome measures related to older adults. Because as Anna was saying, right, this is the plan we're going with for 3 years. But if the concerns that are in the community about how well this is going to serve older adults are true, and we have some outcome measures that can be evidence for that, it would really be a powerful tool for advocacy for making changes to the BHSA going forward.
Thank you, Barbara, for that thoughtful recommendation. Anyone else?
I want to, I guess, highlight some recommendations that I think need to be shared between, well, the need for specific focus on finding effective methods of reducing loneliness and isolation in older adults, right? Yeah. Right. Then 2, we need more investing in California research on the impact of loneliness and testing individual cases to make social isolation a thing of the past. Then I have another recommendation. We need to partner with others, organizations, or other researchers or something to
I think the other state agencies.
Yeah, state agencies to create solutions. We need to kind of expand this out a little bit more. And then 4, need more than just robots and AI to solve this problem of loneliness and engagement, social engagement. And then that's 5 programs. We need more programs to pair seniors with young people. I think that's, we need to bridge that gap of the with the intergenerational kind of connection. What else? And we need Medi-Cal to pay for adaptive equipment like a bicycle or something that for elder communities to have that social prescription how we can kind of get that implemented. Then what else? We need more training in fundamental research and how to care for the caregiver. Caregivers, we need support. That's another deeper dive. And we also need a task force on the loneliness to address the entry level of not only the patient but the caregiver, and then just to highlight the need to elevate isolation and loneliness and make it a priority in California because of the growing population of elders and their loved ones that care for them. See, Dr. Mobley, you have your hand up.
Yeah, I just want to second what you just said, Carlos. I think what you said is exactly right. And you know, it would be important that this be a real thing, not just kind of a statement made, oh yeah, that's really important, but really a concerted effort to put energy and people and experts together around what this might look like as a research and clinical mission and a training mission for caregivers. So I would like to make sure this is really highlighted as something that it's not just we're sending them a note, we really want something significant to happen, and we're hoping that they'll engage the leadership of this committee in moving it forward.
Thank you, Dr. Mobley. I think I agree with you. We just need more than just a statement. We need voices to be heard, seen, and then action to be taken. And I appreciate you all kind of understanding that as we move forward and making an impact. Anybody else have any comments or anything to add?
All right, looks like there's no one else wanting to add anything to our letter, but it'd be great if you could also help us with any suggestions for meeting topics for the rest of the year. Any special requests for last two meetings of the year?
So when the meeting in November, that's the one where if possible, we're going to try to be in person, right?
I don't think we've discussed that yet this year, but I think this would be a good time to discuss that now. So in the past, we have recommended that all committee members, if possible, can attend the meeting in person one out of the 4 times we're supposed to meet. So in the last 2 years, we've chosen November to be that meeting. Anyone has any thoughts about that? Is that something we should continue to do, or are we content with having all virtual meetings for the meetings for the year?
This is Jackie Tompkins, really quick. I just wanted to make sure for this year specifically, the last meeting, I believe, is an October timeframe, not a November like it has been in the past. So just wanted to flag that for the group.
Thank you, Jackie.
Kind of calendars out those months.
So
Thank
Jackie,
you, Callie, for bringing those up.
Do you know the specific date in October?
Looks like October 29th is your final meeting of this committee.
Oh, yes, you're right. I see it now in my calendar.
Yeah, no worries.
Thank you for
And
clarifying
then
that.
just as a reminder to everyone, we are pulling together like an all master plan for aging committee meeting that's happening early December. And that one I believe is December 3rd. Don't quote me on that because I don't have the calendar up, but there will be an opportunity for all the stakeholder committee members to come together at that time. So just wanted to flag that piece for all of you as you discuss preferences.
When you say come together, you mean in person
virtual.
come together? Virtual.
Virtual,
Okay.
sorry.
Okay.
Virtual.
Thank you.
Yes.
I would just say, as legislative staff, I do appreciate the virtual option. It makes it a lot easier to actually attend.
Yeah, and I think we're not talking about getting rid of the virtual option at all. It's just whether November could be
October.
October. Sorry, I'm really wedded to November for it. October 2026.
Yeah, even if we do highly recommend having an in-person meeting in October, we will still have a virtual option for the folks who are not able to make it in person. But we have found it very valuable for all of us to meet in person and to be there together and get to know each other better during break time and during lunchtime.
Manur, you have your hand up. Would you like to give a
Yes,
comment?
I agree with Dr. Caneo that it would be a good idea to have in-person meeting at least once a year. Hopefully this October. The only suggestion I would have to change the time from maybe instead of 10 to 11. So those of us who are going to travel from down south to have a little more time, or at least we don't have to get up at 4 in the morning to get up there at 10 o'clock. But I think in person is a good idea.
Thank you, Manir.
We look forward to meeting you in person.
Yeah.
Same here. I was planning to come actually this time.
And then
Anyone?
Lynn, if we have ideas for future, can we email you? Would you like people to email you, or you and Carlos?
Or Brian, I think, is
Or
our
Brian.
main contact person.
Okay.
Yes.
Send me an email.
Yeah.
Okay.
Or you can send it to our engage at CDA. Engage at H. Either way, it'll get to
Okay.
you.
Thank you.
I know we have a lot of experts in the room, and so if there's anything that's you think would be helpful for the committee to learn about, let us know. And you won't be alone, like you've been seeing with all of our topics. We do invite other folks to present with you, and especially folks with lived experience to share that with all of us, as we always find that helpful. I guess going back to that topic of meeting in person, anyone opposed for October, I guess, is the other flip question as the recommended meeting to have in person. Anyone oppose? Okay. So hopefully we will all meet you, not all, but most of you. I have to be careful with my language in person in October, but we will meet virtually in August. Okay.
All right.
Go ahead, Carlos.
Well, I just want to say, I want to thank the presenters, committee members, fellow stakeholders, and members of the public for your engagement, contributions, and the productive discussion today. It was really nice to hear voices in support of invalidating my journeys, as well as the many caregivers that are out there. Yeah. Thank you for your hard work and your commitment to the goals, the Alzheimer's disease and related conditions advisory committee. With no further business, this meeting is adjourned.
Thank you.
Thank you.
Thank you, Lynn, and everyone.
Thank you.
Thanks for coming. Stay connected with our npa.aging.ca.gov, our engage email, engage, ENGAGE @aging.ca.gov. And of course, all our various social media platforms. We have lots of information. So thank you again to our committee members and our guests and our CDA staff. So have a great day. Thanks.
Thank you.